Hello, everybody. I'm Dr. Rebecca Griffith, the ED DPT. Welcome back to our next episode of Admitted or Not. I'm pleased to have with me today Dr. Susie Ryer. Susie, would you like to introduce yourself?
Sure. Yeah. Hi, I'm Susie Ryer. I'm a doctor of physical therapy. I've been in practice for about 20 years here now. Worked in a wide variety of settings, kind of across the board, acute care, inpatient rehab, home health, leadership for a long time. And now currently I work in a project coordination role within a large health system doing geriatric care.
That's amazing. So I think most people who are physical therapists kind of imagine transitioning into non-clinical roles, but really aren't sure what kinds of roles those are. So can you tell us a little bit about what your job is exactly, and do you still provide any clinical care?
Yeah, so in my current role, I'm not doing any direct clinical care. So my role, I work within a department called Senior Services. So we're a system-wide department in our health system that covers 2 states with about 26 hospitals across a pretty large footprint. And in my role, what I do is I work on developing programs, implementation of best practices that really focus on how do we better care for older adults across the care continuum. So a lot of that work focuses on, how do we provide best care in the emergency department? How do we address things in primary prevention with our population health colleagues? How do we provide broader education to clinicians across the health system about unique needs of the older adult population? So I have my hands into a lot of different systems, and I have the opportunity to work with people of multiple different disciplines across multiple different settings at various stages in their profession.
That's so cool. How does somebody get started with something like that? Like, how do you
A lot
how
of
do you bridge that gap from a
a lot of
clinician?
persistence, I think, is probably
Yeah.
the best example. So, my journey to this role was kind of being the squeaky wheel in a lot of meetings, which I think many of us as PTs have probably encountered. Probably 7, 8 years ago, I was invited to a meeting looking at how we care for older adults on an ACE unit, so acute care for the elderly
Yes, we have one of
units in the
those.
hospital. And so, always really interdisciplinary in those settings, with rehab always well represented. And at that meeting, this concept of a geriatric emergency department was being just introduced with
Mm.
how do we provide more unique care for older adults. And it was still in the kind of its infancy. And I just started to bring up the idea that, well, this is a population that really could benefit from physical therapy, from our rehab
Yes.
perspective. And so as time grew on, kind of continue to speak up for ways that we could influence, and how I could share some of perspective from the PT side that would help to influence some of these broader strategies around care for older adults. And so when the opportunity came up within our team to add another clinician kind of clinical perspective to our program development, I joined the team. So now we've got a physician leader, a couple nurse leaders, and then myself with a PT perspective, along with some of our other colleagues who work in data analytics, project management, things like that.
That's amazing. And so what does your day-to-day look like? Like, is it like a 9 to 5 type of situation, or do you go weekends? Do you go travel to different facilities? Like, how does all that work?
Yeah, so I was supposed to start my job in February of 2020. So we can all
Oh,
imagine what that looks like.
yeah, I'm sure it was great.
Actually, March of 2020. So I deferred and stayed in my previous role, helping to support my inpatient team that I was leading. But so my day-to-day actually looks a little different than I think what I expected when I took the job. As you can see, I work from my home the majority of the time. So I work 100% remote right now, which is a little different than we originally anticipated. But I do support teams, like I said, throughout our health system. So right now it's a lot of Zoom meetings still. We do a lot, virtually, just to be able to reach such a large footprint. But I do have the opportunity to go on site and meet with teams. I've done some in-person trainings just more recently. And then having the chance to travel and kind of share some of the work that we're doing kind of out more broadly, even across the country a little bit.
That's amazing. So it sounds to me like, based on conversations that you and I have had, that you have passion for the older adult population. Tell me a little bit about that. Like, how are we doing a disservice to those patients?
Yeah, so I think, with my years of clinical experience, kind of having seen older adults from a lot of different angles, working in critical care, working in acute care, and then moving into the home health journey. I think where we do older adults a disservice is a couple different ways. One, I think we try to apply a one size fits all approach to them across all our settings. And in some areas, acute care, I think we've gotten a little bit better with that. But as we think about the emergency department, especially, there's still very much this mindset of, if you're over the age of 18, you kind of fall into that adult population.
Right.
And our policies, our procedures, even our ideas of how we can discharge and move through throughput is very one size fits all. So I think that's one disservice we do. And then on the flip side, it's the assumption that every older adult who walks into our emergency department is very complex, has to be admitted. We don't know what to do with them, and it's going to be a big mess to kind of untangle. And so we don't have time to do that in the very short time in the emergency department. And so we either tend to miss things, or we tend to, over admit and not, really try to get those individuals into the best location, which for many people is back home in the environment that's familiar to them, that's supportive, where they can have additional services wrapped around them versus, all of the dangers that come with a hospital admission.
Yeah, I think that's so true. I think we also make a lot of assumptions. Like, we make an assumption in the questions that we ask in the history, and we make assumptions when we look at patients, and we make assumptions about that we know what's best for them. And I've found so many times that I can make this like perfect plan for an older adult and think this is the right thing.
Right.
And then when I talk to that adult, they're like, no, like, that's not right for me. I get that you think that that's the right thing, and I get that maybe that's the right thing on paper, but that will not work for me, and that will not work in my life. And so I have never been so humbled as having older adults like really kind of remind me that they are at the center of the care that we're providing, and that I shouldn't be assuming that I know what's best for them. And so that's been a big mindset shift for me.
Yeah, I think there's a tendency to be very paternalistic in our care of older adults. And, there's a lot of movement, in the work that we're doing. And, even in the age-friendly health system movement, if you're familiar with that, that comes from IHI, they focus on the 4 M's around older adults. And kind of the most important of those is what matters most to that individual. And I think you touched on that in this work, what we're really trying to do is center the older adult, their experience, as part of this decision making in terms of what can help them to be most successful in whatever care setting they're in.
All right, what are the other M's?
Medication, mentation, and then mobility. So lots of roles for physical therapists to play in that.
Well, and occupational therapy as well. I feel like particularly in the emergency department, there's a gap that needs to be filled, that physical therapists are not filling comprehensively as we should. And I think that gap could be filled by occupational therapists who can address the medication errors issue. They can address systems to help the older adult manage their medications a little bit better. They can help address gaps in health literacy. They can help address gaps from like ADL perspective of like, how does this person get to their follow-up appointments? How does this person like improve their own self-care? And do they have the appropriate cognition to be able to manage these things independently?
Yeah, absolutely. Yeah. And I think we here in the United States tend to fall a little bit behind our international colleagues. There's some great work being done in Ireland and Australia where, OTs are part of, emergency management teams in the ED and even before, as part of the ambulance service. And so, yeah, absolutely. It's certainly not just us physical therapists who have a role to play.
Yeah, I think that's absolutely right. There's also some new literature about occupational therapists in the management of patients who are experiencing homelessness as well, and how they have an instrumental role in helping decrease unnecessary presentations to the emergency department, which I thought was really interesting. But I guess that's a little off topic. So tell me, like, what changes have you noticed with the work that you're doing?
Yeah, so some of the things I think we've noticed is one that we've been able to, help direct patients away from hospital admissions unnecessarily, especially in the emergency department, trying to improve discharges to home. The other thing that we've been able to see is a much higher percentage of referrals to support services to interdisciplinary teams, a huge increase in physical therapy involvement in our emergency departments, consultations, but then also improving those follow-up care appointments. So referrals to primary care, referrals to community-based programs, referrals to home health or outpatient physical therapy. So that's been one thing we've really seen. The other thing that we've seen is reductions in ED length of stay, which is sometimes kind of the opposite of what a lot of people think will happen when you put a higher emphasis on screening older adults in the ED or bringing in a physical therapist. We're actually finding it shortens the length of stay in the ED and allows for better throughput because those
Yeah.
decision making is happening faster. You're getting the right players at the table and people aren't kind of spinning their wheels quite as much in those early phases.
Yeah, and I think the goal is to get those patients out of the emergency department quicker, right? Like there's this whole concept that the emergency department is no place for the older adult.
Right.
It's not even, I would go out on a limb with an unpopular take that it's not the safest place for an older adult. It's not set up. I mean, the gurneys are very high and not very adjustable. There's not even really a lot of space to roll. There's not easy access to restroom facilities. There's bright lights or no lights. There's no windows. There's like not a lot of assistive device equipment available. There aren't a lot of people present to assist you and orient you and help you call for your meal. Like all of those things are barriers to care for that population.
Right. Yeah, even during kind of the height of, the surges from the pandemic that we saw when we compared our older adult boarders to older adults who were able to get admitted into the hospital, a little sooner, those patients who were boarding had such poor outcomes, especially in the older adult population, much longer lengths of stay, much more likely to end up in nursing homes or skilled nursing facilities, or have other complications related to their care. And a lot of that comes with, like you said, that environment not being well suited to kind of best care for older adults. And that's a concept that the geriatric emergency department that we've really been working on really focuses on is, certainly there's staff components and policies and procedures, best practices for care, but then there's also some of that physical environment stuff. Do you have, rooms or ways to adjust lighting for those older adults? Do you have access to mobility devices that are going to work for them, not just to take home with them, but to utilize while they're in the emergency department to promote mobility? Is there access to bathrooms? Can you avoid placement of foleys? All those things that, really are going to set up an older adult, for better outcomes by making those small adjustments.
Well, and even if those older adults like take medications on a very strict schedule at home, that's not happening in the emergency department either. I mean, they're trying, particularly, I mean, our emergency department has been boarding patients a tremendous amount over the last few years because of the COVID pandemic. And it's been very difficult to get those patients evaluated in a timely manner from rehab services, as well as making sure that they have the support that they need while they're in the emergency department. Because if you think about that poor nursing staff, they're having to also manage all of the patients that are coming in and going out while they have these like stable boarders. But I don't think anybody feels great about like that boarding situation, no matter what facility that you're in.
Right, absolutely.
So let's say best case scenario, like we have all the things we want and we can have ideal state. What does this emergency room look like for an older adult?
Yeah, so really in the best state, you would have rooms or an environment that's set up to specifically care for those older adults. When we talk about some of the accreditation work that's happening, these level ones are considered the kind of the top of the top for geriatric care. So they've got rooms that are dedicated for older adults, the better lighting, they've got beds or sometimes they're even using recliner chairs so that, rather than actually putting someone into a bed-like environment, we're trying to keep them as upright as physically possible. You've got some natural lighting in there or some things to help orient to day and night. You've got staff who are trained in geriatric principles, and you've got a geriatric care team that are coming in to do a more comprehensive assessment. So that might be a geriatric nurse practitioner, a physical therapist. You've got pharmacists who are doing more detailed medication review. And we're really looking at having policies and procedures, and practices that really hone in on those older adults, unique needs. So reducing the use of foleys, looking at medications that would fall on the beers list that are considered,
Yeah.
unsafe or dangerous for older adults, doing medication review in the ED and reconciling those appropriately. And then having a really good care transition team in place to work with the patient, work with the family, consider what matters most to that individual and set up a care plan that's going to really help that person to go to the next level of care appropriately and have the services that keep them out of the hospital, and in the community or wherever their place of residence is.
I think that is such an upstream way of thinking about how to manage these patients a little bit better. And I think too, when I'm discharging patients, particularly older adults, and I'm giving them all of these instructions for follow-up and how to use this assistive device and who I think they should see for physical therapy and where that will be, like, how much of a gap is there, like, with what we're recommending and what actually gets set up for many of these patients?
Yeah, I mean, there's a huge gap. So, we've put a lot of work in the last year on placing these service to or these follow-up orders upon discharge. And, in some of our preliminary study work, like, less than 25% of patients are being captured, are actually attending those follow-ups. And
Oh.
so, where a lot of that comes down to is it's that lack of coordination. It's not knowing who's going to call. It's not understanding when that call comes. I know we've done a lot of work with our rehab departments about explaining at the time of discharge who's calling that individual, and when we can, setting up that appointment, right from the emergency department and getting them scheduled. Because otherwise, you're an older adult, it's 72 hours after you got home from the hospital, you're feeling a little bit better, and someone calls you and says, I have this appointment set up for you, or I need to set up this appointment. And there's just not that understanding of how things, relate and where that need is. And so, a lot of our work is focused on improving that capture through scheduling things in the emergency department. And that's a really foreign concept, is this idea that emergency care should be more focused on what happens after you leave than what happens while you're there. And I think that's been kind of our biggest aha in the last year or two, is that best care in the emergency department is really about planning for what happens next.
That makes a lot of sense. We do have a team of individuals who their job really is to help people set up appointments, to help people identify PCPs, things like that. And I just wonder, like, maybe every emergency department needs like a concierge program that then like makes sure that people have what they need to make it to that next step. Otherwise, what's the outcome of not doing that is that we're going to have more bounce back to the emergency department.
Right.
So by taking that more upstream approach, maybe have you found that reduces readmission?
Yeah, absolutely. We recently completed a study that's in the process of publication that found some really tremendous outcomes when people actually attended those outpatient appointments, and like a 17% reduction in emergency department revisits. So it's really about, like you said, trying to connect people and break down those barriers of attendance. Some of it, in our system, we worked on just being able to schedule those appointments, but then there's that bigger piece of, health equity and social determinants of health. So do people have the transportation, the additional resources they need to actually get to those appointments? And so I think that's an area that we'll continue to see focus on, is, how do we provide that equitable care and break down those barriers to follow up, because we know that plays such an important role in preventing those, those future revisits or admissions.
Well, and I think with hospital capacity issues, access to care issues that we're having, any decrease is meaningful in that particular case.
Absolutely.
So if you're listening to this and you're like, there's no way my hospital has the resources or the time to do this accreditation process, we need every bed we have, we can't make special beds for special people, like, what are some key things that people could implement now that wouldn't really require like a massive shakeup of their organization?
Yeah, so I think the first thing is finding people who have a passion for older adults. I've been amazed by, as we've worked with different emergency departments on this accreditation journey, how many people are, certified geriatric nurses, or people who have a passion, from their own life experiences, who on their own have learned more, and so stepping into those champions, whether it's a nurse, whether it's a physician who maybe did a geriatric, fellowship or residency, or had some of those interactions, can really be helpful, because then they're passionate, and they can be a great source for sharing that information, because a lot of it's just an awareness of, hey, these individuals are different, and there's simple things I can do in my day-to-day practice, how I phrase a question, how I explain something that can really make a difference. The other thing is just really knowing who your interdisciplinary team members are and having a way to access that individual. Not every ED is going to be able to put a physical therapist there 24/7 or a
Right.
pharmacist, but is there a process that if there are those most vulnerable patients, those folks that you really need to have the whole team involved in, is there a workflow you can create to tap into those folks, whether it's having them come down, whether it's a curbside consult over the phone. But I think we've seen the more that we can involve the whole team in the care of the older adult, the better the outcomes are for them and the more that they're satisfied with the care they receive.
I think that is absolutely true.
Yeah. And then other than that, I think it's also just, putting the older adult at the center, listening to where they're at, valuing them and their care team, their home team, the folks that are around them outside of our systems, valuing them as the experts, I think is the most important thing we can do. And I think, again, making that little shift in mindset doesn't take any resources. It's really just about how we approach those individuals.
I like that. So if you are listening and you're that person who's like, gosh, I am fired up about this, I am interested, I am that person that Susie's talking about, what are some resources that you would recommend that person explore on their own?
Yeah, there's a lot of great resources out there. So the American College of Emergency Physicians, ACEP, they have a geriatric focused accreditation group. That's a great place to just go look at what geriatric accreditation looks like. Even if you're not quite on that journey yet, there's a lot of great recommendations for practices, policies, procedures. And then the Geriatric Emergency Department Collaborative, or the GEDC, is a fabulous organization. It's really made up of some of the early trailblazers in the geriatric emergency department movement, health systems, large health systems like the VA, other folks across the country and even into other parts of the world, really. And so they've got webinars that are free and available. They've got toolkits for if you were going to focus on a falls and mobility protocol or you're trying to address dementia, that you can access all those things there as well. They've got some podcasts that you can get to off of there. So just really a fountain of knowledge there as well. Also, there's the Journal of Geriatric Emergency Medicine, which is a relatively new journal that's in the process of getting PubMed index, that's got some great original research as well as case reports and studies. That's just a great way to learn from that interprofessional team about older adult care in the emergency department.
Awesome. And for physical therapists, are there any APTA resources you would recommend?
Yeah, I would go out to APTA Geriatrics, even though it's not specific to emergency department. They've got a great especially the Balance and Falls group put together a really nice toolkit on best tools to use for older adults. If you're looking at picking a balance or mobility tests, screenings that would be really applicable in that setting. So I would highly recommend going out there and taking a peek.
Love it. Okay, so are you ready for the case?
I think so, yes.
All right. So every time we have an episode of this podcast, admitted or not, we talk about a case and we try to decide, was that patient admitted or not? Like, did that patient have a successful outcome to discharge from the hospital, or were they admitted to the hospital? And then, like, what were some lessons learned from that particular case? So I'm ready if you want to.
All right, here we go. So this is a 92-year-old woman. She came from an independent senior apartment complex by ambulance. She had a fall. She was stepping backwards to sit in the chair, and she fell. She lived alone. She used a walker. They did imaging. Her medical workup was negative for a new fracture, but they did find she'd had a T12 compression fracture in the past. She was diagnosed with acute low back pain. And that's all I'll tell you about her so far.
Did they do a CT of her back?
They did not do a CT, no. No CT. The rest of her medical workup was pretty unremarkable. She did have pretty high pain numbers throughout the time that she was in the ED.
Did she have any back pain before this incident?
She'd had some intermittent back pain, but her acute pain was much more significant than it had been previously.
Is she aware that she had a compression fracture there?
I do not believe I think she was aware that she'd had a compression
Okay,
fracture.
so that wasn't new for her.
No, no,
Okay, and then normally uses a walker. How's her cognitive status?
they did not assess her cognitive status.
Ooh, well, what would you suggest?
So I definitely would suggest some kind of screening be done. In our setting, the mini cog is usually what they're using. So
Mhm.
definitely something like that would have been important to understand.
And what would they have found if they had completed that?
For her, they would have found that she was that her cognition was intact.
Okay, good. And then does she take a significant amount of medications?
Her medications were fairly. She took something for blood pressure. Um, and then other than that, she was taking some pain medications. So she did have a couple prescribed pain medications. I think she was on Toradol at one point.
And no underlying health conditions other than the
No,
hypertension?
other than the hypertension, no.
And how are her vitals today?
Vitals were stable.
Good.
No issues with blood pressure. Heart rate was a little elevated, probably related to the pain.
Sure. Any hard neurologic signs that we're concerned about?
No.
Okay. And how is her mobility?
That's a great question.
Yeah,
So
that's
the reason-
such a PT question, right?
Right,
I'm like,
right.
all these things, I want to know these things before we
Right.
get up, but now that we're ready to maybe get up, how's
Right.
that looking?
Right. And part of the reason that I picked this case to talk about a little bit was, so this was a patient where they actually never assessed the patient's mobility. So this was a
Yikes.
patient that we had been seen. And so had the mobility been assessed, they would have found that the patient had pretty limited mobility, was having a hard time with the walker because of the back pain, really, antalgic gait pattern, very slowed compared to her baseline.
Yeah. So and you said they never did a CT. I probably would have recommended a CT for this patient just to make sure that they weren't missing any new fractures that they weren't able to assess on x-ray for her. And so, I mean, in this case, I probably would have referred this patient to subacute rehab if that was within her goals of care, because she doesn't sound like she's able to return to home independently.
Right.
And it also doesn't sound like she's moving well enough that home care would be a safe option for her. Was she agreeable to something like that?
Well, so what's interesting about this case, and that's part of the reason I selected, was that she actually was discharged back home.
Right, because we missed that, right?
Yeah.
We missed that she couldn't move.
Right. And a couple of things were missed. So that was missed. And then the other piece with this patient that again comes to that really digging deeper in understanding where someone came from is, I know in our communities, we have a lot of these multi-level care facilities.
Yes.
So independent, assisted living, skilled nursing, all can come from the same location. So when this person came in, it was documented that she'd come from skilled nursing assisted living, when in fact she lived in the independent part of this
Yikes.
Complex.
Yeah.
And when she was discharged, the plan was that she should have gone back via transport from that facility. So had that happened, I think a lot of bells and whistles would have gone off saying, hey, she can't get into the transport van because she's moving so poorly. But because that wasn't available, they sent her back by ambulance. So she came in by ambulance, stayed on that cart, had her imaging, and went
with
back
horrible back pain. Yes.
Yes.
So this does happen, and one way that we mitigate that as physical therapists is when we're receiving the history from the patient, is I always say, so where you live, is that independent living, assisted living, or skilled nursing facility? And I always explicitly ask, what services do you receive in your home, whether that patient lives at home or not?
Right.
And I think that would have been a really good way to identify that this patient is on her own. That just because they have that in the building doesn't mean she has that.
Right.
So did this patient bounce back?
She sure did. Yeah. So she was back in about a day and a half because she went home and she started taking more pain meds because her back pain was worse. She wasn't moving. And so she actually ended up coming back into the ED, having to be admitted because of constipation and poorly controlled pain. From all that pain medication. And then she actually ended up developing delirium. And then she did end up having to go to subacute. So she had a very long extended kind of stay, from the fact that was kind of missed.
Oh my gosh.
So I use this case in a lot of the teaching I do, and really the justification for the program and the work that we're doing, because here's a patient who came in from a for a fall, with the right screening tools. So, in our health system, we've started to implement for sites that don't have, ready access to a physical therapist, do you do a timed up and go? Do you do something to at least screen these patients who've come in for a fall?
Or even just walk them to the bathroom. I
Right.
mean, it
Even that
doesn't
would be
even have
great.
to be like
Right.
a
And so,
stopwatch type situation.
right. But just having that, having that eyes on things and then asking those questions and doing a little bit more detailed screening. In our settings, we use something called the Identifying Seniors at Risk, or the ISAR, which is a 6-question screening tool that our nurses do. And, part of that is scoring that, but then also digging a little deeper and adding some comments that can direct case management, the physicians,
Yes.
about what happens next. So, like you said, had that question come up about, tell me more about, home, what that looks like, that would have flagged a lot of things and helped to maybe pull in, a physical therapist to look at this patient,
Yes.
to have someone at least mobilize the patient before we sent them back home.
Yeah, I think that that's really smart. I also wonder too, like, could there have been any like manual therapy techniques that might have made this patient feel better to the point where she could have gone home with some home health services and been successful from ready go? Like what other interventions could have been offered to this patient in this particular setting that a physical therapist could have accommodated? That breaks my heart. We see a lot of patients in this exact situation.
Yeah, absolutely.
And there are those that do not want to go on for rehab services and do not want to be admitted to the hospital. And I do send those patients home with as much support as possible, but I do wonder about their outcomes sometimes as well, and how they're doing back in the community. But
Yeah.
I don't feel like this lady got a fair shake.
No, and and like you said, even some kind of a follow-up services. I mean, it was really just that assumption that she, again, it was going back to that assumption that she had everything already that she needed, that there wasn't something new we could offer. And so,
Yeah.
Even on top of missing some of the pieces that maybe would have triggered different interventions or different referrals in the ED, it's that idea that when they leave our doors, that we're done. And that's not a good way to approach care for anyone, and especially our older adults, when
No.
they're leaving a vulnerable time in the emergency department and then going back to the community or wherever they may reside.
So I think bottom line, like when we say the emergency department is no place for an older adult, like if we all work together, we can change that. So I appreciate having you today on the podcast, Dr. Ryer. We thank you for listening. If you want to learn more from Dr. Ryer, you can check out our blog. You can subscribe to our YouTube channel and our podcast to learn more about practice in the emergency department, because we make PT in the ED well known and well practiced. Thank you so much for your time today.
Thank you for having me. I appreciate it.